1 plus 2. That's all. You saw this? And she has to keep looking here. That's it. Now what you are going to do, what is normal, what is abnormal, I am going to put. If you don't see any eye movement after the head movement has stopped, it is normal. That's all it is, how to interpret. Okay, why I am stressing on this is, interpretation of head impulse test itself goes through problems, so we need to, because I run a course, I send videos to people, I ask people to just tell their interpretation, and then I see people struggling to tell what exactly is a impaired head impulse response. Impaired head impulse response means when I start the movement and then I stop the movement. Once the head movement stopped, I should not see any eye movement. What is the meaning? What is vestibulo-ocular reflex? Vestibulo-ocular reflex is when the head is moving like this, when the head is moving, eye is moving in the opposite direction. So which means eye is moving in the opposite direction and fixing the gaze. So she is holding like this the gaze. She is holding the gaze like this. When the head is moving like this also, it is still maintained. The gaze is still maintained because the eye is moving during the head movement. If the eye is moving during the head movement at that rapid pace, that means the VOR is good. So if the eye did not move when the head movement was happening, if it went off like this, then she looks like this. This is VOR was not working. So how to interpret a head impulse response after the head has stopped? You can't fake it. So once it stops, I should not see an eye movement. What is happening during the head movement, that eye movement cannot be seen. It's not that easy to appreciate. Basically, you should not see an eye. If you see an eye movement, that is what is called. So what is the name given for that? The name given for that is corrective saccade. Come inside, don't. Is really grossly motor weak, already has a stroke. It is very bad, this situation. Okay, so there is this, already has a stroke. Okay, already this thing grossly motor weak. Okay, this is the kind of things person has. Okay, there are people in whom this is very important, making the person stand with eyes open. There is an example of a particular patient who has gone. For what they will tell, for all the things they will tell vertigo. They go to the first time, they say, MRI done. Primary consultant has seen, sent for MRI. MRI normal. Then my friend Frankie Jose from Kerala, patient has come to him for ENT opinion. Final ENT clearance and then go home. Then he tells, somewhere he told, I was keep telling, make them stand, make them stand, make them stand. He made him, there is a fear of standing, means they tell, no sir, you are making me stand, I cannot. But if you insist on him to stand, he will stand. I have recorded multiple records. I have recordings of people with acute vestibular neuritis who can stand with eyes open and eyes closed. If a person is not able to stand with eyes open and eyes closed, it is not vestibular. Especially a person who is a pusher. You are trying to hold, but I am trying to push against him. He is a stroke person. A pusher is a stroke person. Okay, remember the word pusher. Support seeker is different. You try to hold on and he is okay, little bit. He is okay. But pusher is stroke patient. Okay, fine. So that is the next thing to keep in mind. Here, first step you are going to make the person standing. You ask the person to close the eyes now. On closure of the eyes, if the person becomes unstable and he falls, you are dealing with a person with proprioceptive loss. You are clearly dealing with a person with proprioceptive loss. That is all. There you make the diagnosis. Either with eyes open or most of the time in the clinical practice, the moment you close the eyes, the person is going all around the place but does not fall. He is going all around the place, is doing all these things. This person's need next day, immediately after that, you have to take him for student counseling, career counseling, marital counseling. This is the problem with this patient. Okay, that is all. This is a condition called astasia abasia. Astasia abasia in a patient. To do this much of movement without ending up falling needs more balance than simply standing. Okay, so this is what. You can be little more sure my friend Pratik has taught me this one, where you can take the person's hand, eyes closed, to just convince yourself, and write A and ask them to tell what have I written. Then 1, 2, what have I written. When the person's attention is taken towards that, momentarily, first attempt, the person is going to become better, more stable. Momentarily, because second attempt you do, they know this fellow is fooling me. Then second attempt they still continue to shake. It is like that. They are very smart. Okay, so we have to read. Don't put this in YouTube because patients are seeing my video. And next day they'll okay, fine. So this one is proprioceptive. The next thing about this thing is, if they pass this step, okay, you proceed to the next step. If they failure, there only it is. You made the diagnosis, whatever. If they pass the step, next thing, what is the first thing you are going to invest in your clinic? In your vestibular clinic? A small book called Dizziness by Adolfo Bronstein. The first equipment you are going to buy is a book. The book name is Adolfo Bronstein Dizziness. It's available on Amazon. Second thing you are going to buy is a 128 Hz tuning fork. Okay, 128. All of you have high 12, correct? No? 1024. 256, how many have? 128, how many have? Good. So how many people have 128? Next day is you are going to buy the 128. Why? Where are you going to use the 128? This particular person who became more shaky only on eye closure and is about to fall like that particular person, you are going to do the vibration test with 128 Hz tuning fork. If the 128 Hz tuning fork vibration test on the medial malleolus and lateral malleolus, the vibration is lost, you are having a patient with large fiber neuropathy. You will get hardly one patient. Why don't you come inside? I feel very bad. Because that will prove that vibration sense is there or not. The next investment I want all of you to do is buy a hard rubber, high density foam. It's called high density foam. Okay, buy a high density foam and keep it in the clinic. Okay, so the foam test is the test that you are going to do. You are going to make the person stand on top of the foam with eyes open. Make them get the stability. After that, you are going to make the person close the eyes. You got it? Eyes open and then eyes closed. With the eyes open, if the person is stable, on closure of the eyes, if the person is about to fall, it is a clear-cut vestibular problem. If the person falls without any directionality, he falls to right, he falls to left, he falls forward, each and every time, you are not sure, there is no direction specificity, you are dealing with bilateral vestibular loss. If there is a clear-cut directional pulsion in only one direction, there is a unilateral vestibular deficit. If the right side is weak, they keep pushing to the right side. You can reconfirm this by just changing the head position. If the person is falling to the right side, you can prove that the weaker ear is the right ear only by turning the patient like this and close the eyes. They will start falling forwards. You turn the patient like this and close the eyes, they will start falling backwards. They will fall towards the weaker ear, not to the right or left. If the weaker ear is towards the front, they will fall front. If the weaker ear is towards the back, they will fall back. This tells this. So, you all know how to do a head impulse test, correct? We all practice this, we all know how to do a head impulse test. The next thing that you learned was the Romberg test. Two modifications of Romberg test, foam Romberg test, and this one is stable surface Romberg test and cushion Romberg test or foam Romberg test. Okay. Okay. You will come to Bangalore. I will give you foam. This thing. So as minimum 6 inches foam is what? 60 centimeter by 60 centimeter wide. That is how the foam should be. Okay. So on that foam, the person has to stand and then make. These small things will teach a lot, will give us a lot of information. No vestibular clinic is complete without a foam. Okay. The next thing that you are going to invest in the examination is something called as a Frenzel goggle. Okay, Frenzel goggle. Frenzel goggle is not to, if you want to buy it from the market, Yeropai University makes them. Okay, that Vijay Lakshmi is there, we can share the details with you. Okay, you can, you go to your optometrist, write +20 and give it to them with a large frame choose and they will make a goggle for you. Okay, that is the next thing. Because removal of fixation to examine the eye movement is a very, very important thing. It's a very important thing. Somebody may be there 2 days. There are some people whom I have actually thought this fellow is faking things, it must be psychiatric and all those things. But once you remove the fixation, you start seeing nystagmus, you know that all this is secondary. The psychological manifestations are secondary, that there is a primary problem that this person is going through. So you need to look at the person's eyes on removal of fixation. And when you look at the eyes and remove the fixation and see, you see what is called as a nystagmus if the person has a vestibular asymmetry. What is the meaning of nystagmus? Sir, come inside, sir. Nystagmus is a nystagmus. Okay. Sir, come inside.
Sumit, sir. Come inside.
Just looking at the
Fixation. Gross nystagmus you can see with fixation. But the problem is, there is a person who continues to have a problem. You have one particular group of patients who will come and tell, when are you busy? They will tell all the time. It's a very, very difficult patient group to deal with, because they will tell, when are you busy? This is a very significant part of the OPD where they tell all the time I am busy. You need to have structure to examine this particular patient. You need to have a mental structure and you need to have an examination structure to examine. This particular person can belong to 3 categories of problems. The third category is that he is actually functional. Okay, but that category we will reach after finishing category 1 and category 2. Category 1 is a person who has maladapted to his vestibular deficit. He has maladapted to his vestibular deficit. Category 2 is a person who does not have a vestibular deficit. He has a problem with his brain. It's a degenerative problem of the brain which is causing gait abnormalities. Category 3 is a patient who is telling all the time dizzy because of some other underlying medical condition, and if there is no other underlying medical condition, it is functional. Category 1, 2 and 3. This patient group needs your nystagmus examination on the removal of fixation. The presence of a nystagmus can come forward. Some more people, please make way for some people. Very important to make sure that the person does not have nystagmus, because jerk nystagmus simply means vestibular asymmetry. What is the meaning of vestibular asymmetry? The right ear is not as strong as the left, or left ear is not as strong as the right. Or the superior canals are not as strong as the lower, posterior canals, or posterior canals are not as strong as the Simply presence of a jerk nystagmus is simply means that there is a vestibular asymmetry. That vestibular asymmetry can be from the interoral asymmetry, or it can be between different sets of canals. So jerk nystagmus is there or not there is what you are going to see. If the person can demonstrate a jerk nystagmus, and the jerk nystagmus corresponds to what is called as a vestibular nystagmus. Okay, vestibular. What defines a vestibular nystagmus? Vestibular nystagmus simply means horizontal torsional nystagmus, which is more on removal of fixation, gets suppressed on allowing fixation. Okay, this is vestibular nystagmus. Simply, if you simply want to describe this nystagmus, you simply tell, I saw a vestibular nystagmus in this particular patient. What do you mean when you say that I saw a vestibular nystagmus in this particular patient? You saw a nystagmus which has a horizontal component and a torsional component. Maybe a little bit of vertical, but horizontal torsional definitely is there. And that nystagmus is more on removal of fixation, less on allowing the fixation. Second category thing about that fixation, it also follows the Alexander's law, which means if it is a right beating nystagmus, looking to the right, the nystagmus becomes more. Looking to the left, the nystagmus almost disappears. If it is in the center, you tell that there is a primary position vestibular nystagmus. Okay, if you see a vestibular nystagmus, and if this particular patient has been chronically dizzy, he comes and tells that I have been all the time dizzy, comes say 6 months, 7 months, 8 months, underlying vestibular deficit has now, he is not adapted to it well, or he has maladapted to that vestibular deficit, and therefore this person is very important information. This person will not get a psychological diagnosis. This person will get an actual vestibular diagnosis and undergoes treatment for the vestibular condition. Why does this person have this problem? They go through maladaptive behavior, or they have not compensated for their vestibular deficit. Why does a person not compensate for their vestibular deficit when there is this thing? They don't compensate for their vestibular deficit because he's been on a long-term anti-vestibular drugs. Okay, somebody has given, they take one more opinion. one more opinion, another 3 weeks, take another opinion, another 3 weeks, another 3 weeks, it becomes 9 months of treatment or continuously one brand after the other brand of the medicines. That is one of the causes for. Second reason why the person will not go, commonest in clinical practice is the person also has a BPP. When they have a concomitant BPP, which is a very common consequence after vestibular neuritis, again this person will not compensate. So you have to ensure that this person is not on medicines, this person is not having a underlying another concomitant vestibular condition like BPPV, that is what most important. Then you have to ask the person what exactly is the deficit. Now we go back to our previous examination. What was the examination? We talked about foam test, correct? In a person with only vestibular deficit and with eyes open, they are stable. With eyes closed, they become unstable. But a person who has maladapted will start depending too much either on vision or on proprioception. Too much dependent on one to that extent that they may become visually dependent or surface dependent. Surface dependent patients, when you make them stand on the foam, even with eyes open, they are shaking. Because they are very much dependent on the surface to get their stability information. So they typically tell on the carpet, they are more unstable. They are more unstable when the surface is uneven. These are the places where they have a problem. Visually dependent persons will tell what is happening now. Sir, when I scroll the screen, he is telling when you are dizzy, all the time dizzy. Now you are asking the history about how do you behave in different. Now you are going to ask them how the scrolling on the phone, how do you tolerate it? Car chase scenes on the TV, how do you tolerate it? The train moving, the bus moving, the car moving, fast moving objects in front of you, how do you tolerate it? If the patient tells that is very problematic, then this person has become visually dependent. Now next further question you are going to ask is, every time you scroll the screen you are having a problem, or some days are good days, some days are bad days. If every day he is definitely visually dependent and there has been a previous vestibular deficit as an explanation for it. Some days I can't, there are other days I can do anything. You are having a patient with vestibular migraine. Vestibular migraine also has visual vertigo. Okay, if it is episodic, it is vestibular migraine, it is constant, it is a visual vertigo because of maladaptation. So this is the next test. So just to reiterate, first cornerstone test that we all need to know is a head impulse test, which all of us practiced on one another, we know the technique. The next thing was Romberg's test. In the Romberg's, we have two varieties of Romberg test, variety number 1 of Romberg test and variety number 2 of Romberg test. Variety 1 is stable surface Romberg test, 2 is cushion surface or foam Romberg test. Okay. Stable surface Romberg test was for proprioceptive loss. Okay. But there is also another condition which you can pick up in a stable surface Romberg test itself, that is aesthesia, abasia, which is part of conversion disorder. The person goes all around the place without falling. That is aesthesia, abasia, that is conversion disorder. On the foam, if they pass the test of stable surface, then you proceed to cushion surface Romberg test. In cushion surface Romberg test, you now know two patterns. Pattern number 1 is vestibular pattern, pure vestibular pattern, where only on closure of the eyes they fall or they become unstable. Or pattern number 2 is called surface dependence pattern, where the moment they are on the foam, okay, these are the people who are maladapted to their vestibular deficit. The next thing with the removal of fixation you are not supposed to see is a nystagmus, not the vestibular type of nystagmus. I described what is a vestibular type of nystagmus. Pure horizontal nystagmus, not vestibular. I am not talking about the positional. In positional, lateral canal can cause pure horizontal. But if you get in a spontaneous nystagmus which is pure horizontal, spontaneous nystagmus which is pure torsional, spontaneous nystagmus which is pure vertical, it is not from the inner ear. Okay, pure. Inner ear is vestibular nystagmus is horizontal torsional nystagmus. Okay, it is horizontal torsional nystagmus. You have to remember that. So now, the next thing that you are going to look at is, I told you there are 3 categories of people who come with chronic dizziness, all the time dizzy. Category number 1 was they have a vestibular deficit, they are maladapted to the vestibular deficit. Category number 2 is they have a condition in the brain, a progressive condition, progressive disequilibrium. Some degeneration is happening or something is happening which is making them imbalanced. It can be simply cerebellar cause, it can be Parkinson's, Parkinsonian disorders, these kind of things that are happening. In that, there is one common which is very difficult to diagnose unless you use Frenzel's with removal of fixation. Downbeat nystagmus. So you have to look for downbeat. If the person has a downbeat, then that is the cause of this person's disease. Okay? So this is one. Then you have other condition, other diagnosis for Parkinson's plus these kind of things, which we will deal in the next section. How to actually diagnose patients with Parkinsonism, how to diagnose patients with cerebellar, all these things. So that is that. If they pass these two things, then he is simply chronically dizzy for the last 6 months. He can have nutritional deficiencies. He can have thyroid problem. In a nutritional deficiencies, especially in the background of alcoholism, the person may be having a B1 deficiency. B1 deficiency is an under-recognized cause of balance problems. B1 deficiency. When experimental B1 deficiency was first introduced in chicken beriberi was introduced, the first sign that was manifested by this chicken was actually ataxia of meat. Okay, that was the actual this thing. But now we are not even talking about that as a condition. Okay, we are not talking. Okay, but B1 deficiency is one common cause. If you want to do 2 nutraceuticals from Monday onwards, which will start helping some percentage of your patients, is magnesium, B1. But B1 tablets will not give the dramatic relief. This one or this one. Okay. 500 mg is all. Okay. 500 mg. Okay. You can give it intramuscular or you can give it this. Okay. That is the next thing. So if you have a patient who is like, so in between the second category and the third category, the other differential feature is, in the second category, you will be actually able to demonstrate physical signs of ataxia. Okay, person will not be able to stand a tandem. Okay, these kind of things will be there. The person will not be able to do what is called a retropulsive pull test. I will come to that later. Some sound is coming. Look for hypothyroidism, look for liver problems, look for problems of uremia. This kind. If everything is normal, mostly your patient without at that stage, don't hesitate. Ask them to now go meet a psychiatrist. Okay, meet a psychiatrist. And for me, my psychiatrist, whenever I send this, after all curating all these things, I send to the patient. Psychiatrist send general messages. I can show some of the messages. Thank you for referring this patient. She was severely depressed, almost considering suicide. I did not know that. Okay, to that extent these people are. So once you have curated all these things and you know now you are doing it, this person goes to, and we are actually saving lives by sending them to the psychiatrist soon. Okay, so there are so many things happening in life. The thing that we are talking about is a person who comes with the falls. Correct? A person who comes with falls. What are the things? Person examination. Okay. A person who comes with falls, especially 50 plus somebody comes with falls, one diagnosis which goes undiagnosed for a long time, up to 1 year, up to 1.5 years, is a condition called progressive supranuclear falls, PSP. This presents as falls. The presentation is as falls. And the diagnosis of this one condition actually rests on examination of the eye movements. So, what are we doing with? We are seeing with clinical problems in hand and we are doing things. It is not like we have one pro forma for all patients. Correct. So person comes with falls and especially the person is 50 plus. Or first thing you are going to do, don't even take history. No further history, nothing. At this stage, stop and immediately do what is called as an eye movement examination, range of eye movements. Look up, look down, look up, look right and look left. That's all. You will pick up the diagnosis of progressive supranucleoplasty at this stage because voluntarily eyes moving up and down is impaired in PSP. Voluntary eye movement, okay. First eye movement to be affected is vertical gaze, especially downward gaze. Person cannot look down. So that is the place. A person comes with falls, you are going to do an eye movement examination. look up and look down, look up, look right, look down. If the person feels you are not sure, this person is a little bit restricted, I am really not sure whether it is completely restricted or not. You now test what is the person's full range of eye movement. Compare the voluntary range of eye movement with reflex range of eye movement. You got that? Okay. Kapil sir, you are chair now. You sure? Yes. So, what you do now, you ask the person to look up. It is moving little. Look down. It's moving less, little. You are not sure whether that much only is there. I have not done many examinations. What to do? Now you do. Ask the person to look straight and then look. Do this. Now, if the eye comes full down, this is reflex movement. Then this is actually reduced, the volitional. Progressive supranuclear gaze palsy. The nucleus of the cranial nerve which is supposed to move the eye. There is a command to that from above the nucleus, there is a command to that from below the nucleus. Command from above is the person's frontal lobe telling move up, move down. Command from below is the vestibular system sending the supply to the same thing. When my head goes up, the eyes have to come down. The palsy is restricted to supranuclear, not infranuclear. Okay, you remember what is PSP now. Okay, progressive supranuclear palsy. Okay, PSP, especially the gaze palsy. Okay, so this is a vertical gaze palsy is what you do. Every fall patient, your examination has to begin with eye movement. Then after this, you take history. You are going to ask the person, describe the fall. What happened? The person tells me, sir, no, you tell me, when was the last time you fell? I fell last week. Now you tell what all happened. Where were you at that time? I was at home, I was at the grocery store, I was at this, so and so, all the description. Just listen to the description while on the background you are trying to filter that for certain type of information. What is the type of information you are trying to seek from that thing? Does this person seem to be aware of all the things that happened? That means he was conscious and he fell. Okay? He was conscious and he fell. Person tells, no sir, when I woke, then they were putting water between, I didn't realize. He was not conscious. Don't tell did you lose consciousness. Patient will tell to just tell that it was too bad, they will tell I lost consciousness. I have seen patients. So don't ask that question. Just ask them to describe and then you get what is the. Because from here, if you get a clear answer as to lost consciousness or not lost consciousness, the differential diagnosis branches. If the person had lost consciousness and had fallen, there are 4 differential diagnoses which you can make very easily. Differential diagnosis number 1, he had a seizure and he fell. Differential number 2, he had a syncope and he fell. Differential diagnosis number 3, he had what is called as a syncopal migraine. Differential diagnosis number 4, he had this particular person has a conversion disorder. It is psychogenic non-epileptic seizure, PNS. Severe stressors. They are not able to come out of certain situations they have put themselves in. They throw up this. Yes? So these are manifestations of unresolved conflicts. Show up as conversion disorder. Unresolved conflicts, they show up as conversion disorder. So you know the clear cut. Lost consciousness, only 4 things you are thinking. Multiple choice questions. NEET exam it becomes now. That's all. Lost consciousness and fallen. 4 diagnoses you are going to think. So seizure. Seizure disorder person, he will jerk and he will fall. Post-ictal confusion. Some of the things. After getting up, the person remained confused for some amount of time. Post-ictal confusion. Seizure disorder patients are also prone to getting themselves injured, tongue bite. These kind of things will happen in seizure disorder. They are stiff when they fall. Syncopal patients have a premonition. Syncopal patients have a headache before. Sir, from morning I was having a headache and all those things on that day. I had taken a tablet, I was really not great, feeling great, and then I went and I fell. This is syncope. I was standing in the queue, bored, I was standing in the bank, I was standing somewhere, it was getting bored, nothing, then suddenly fell. Principal is talking about the future of the country, the boy is falling in the school prayer. Okay, this is very common. These kids are brought, but we know that it was a syncopal form. Okay, this is orthostatic dysregulation with the loss of consciousness or near loss of consciousness. Hypoglycemia is not associated with postural instability. This comes with a study with multiple people who have seen, who treated patients, who have witnessed cases of hypoglycemia. Did you actually take care of a person who had fallen? No. They are sweaty, they are doing this thing, they are scared. So much is happening, but they are not people who have been found fallen. That is too late. That is too late. They are found fallen, it is too late. Is that okay? So like that. This comes from a study. So we did not have to think of hypoglycemia as a this thing. Okay. Why then so much of story would have happened by the time that fellow actually. So there are 4 differential diagnoses you are going to consider. So I had an headache from this thing. I was getting a premonition. My face felt warm. All these things happened. Then I felt it is a syncope. That was a premonition. Or prolonged standing, being bored for a long time, then for syncope. Okay? But if the person comes and tells that this is not this, after getting up, after having the fall, severe headache, seizure, headache and fall, syncope. Fall, get up later and afterwards had a headache, post-ictal headache, seizure. These are the kind of history points which are going to help us between the two things. Lot of migraine history of migraine in the family, personal history of migraine, motion sickness, lot of all these problems are there. That person has also fallen syncopal migraine. Syncopal migraine is one under-recognized cause. Okay, syncopal migraine. There is a variety of migraine in which person has syncopal attacks again and again. The last one is psychogenic non-epileptic seizure. These are the person, they will 100% fall in front of you. Yes. They will fall in front of you. All of these patients. I have seen them. Second thing is, you can actually, this is something called inducing the fall or inducing the loss of consciousness. As a test, clinical test of psychogenic non-epileptic seizure. You will tell, I am going to press one nerve. I know what is your problem. Severe only, serious only. In that problem, if I press one nerve, you will fall, and then you just press that nerve. that person will fall. Cataplexy, gait disorder. Vestibular, cataplexy, gait disorder. 3 types of things. Vestibular fall is a fall in which this fall is because of a vestibulospinal reflex, which is trying to make the person orient himself to a line of gravity, but that line of gravity is wrong. It is not the true line of gravity. Typically, you will see, where is Dr. Bhavin? Dr. Bhavin's patient is there, become world famous. His video was there, all the places. This is a person who, after repositioning maneuver, is there standing, talking, everybody, suddenly is walking like this. Suddenly, as if a ghost has come from back, lifted him and thrown him on the ground. He falls like that. I think that video should be shared to all the delegates. We'll share it to all the delegates. As if you don't believe in ghosts, you see that video, you start believing in ghosts. If you don't know what is happening. It is like that, because it is as if the person has been held up like this and thrown like this. It is like that. Okay. This is rapid vestibulospinal reflex reorientation towards a wrong line of gravity. Towards a wrong vertical. What is the story here? The person is completely aware of what is happening. There is lot of force. In the semantics of the description of the language, you will know that there is a lot of force there. There is force that talks about force. Sir, suddenly I felt pulled like that. They will not tell, sir, I just collapsed. Syncopal fellow collapses. This person is thrown. This is vestibular fall. But the moment the person tells vestibular fall, does not mean that he has only Tumarkin's otolithic crisis. Vestibular falls can be of 4-fold causes. Of them, the commonest one I will tell last, because climax will come. Okay. It can be because of Tumarkin's. It can be because of BPPV. BPPV patient falls during 2 times. One is when the debris is getting loose from the utricle. At that time, I may be simply giving a lecture. At that time it becomes loose, at that time I will fall. Second thing is after your repositioning maneuver. After repositioning, don't send the patient outside for next half an hour. I have had patients who have come back to the door frame, they have hit badly, came with BPPV, still BPPV. You have to test again, If 2 tests, 3 tests are negative, the clinical history is still strongly BPPV. You have to ask the person to stop the medications, come back and then test. Only after, because lot of BPPV start showing up in the third time. Lot of BPPV start showing up after 50 seconds. So if the clinical history is strongly of BPPV, you know the typical BPPV is I'm changing the position for a few seconds, the vertigo comes, it's really spinning vertigo and all those things. And if your test turns out to be negative, don't tell that there is no BPPV. Please retest. There is one particular test for BPPV. This is the upright positions test. You first start off with pre-manipulative. This is just check the neck range of motion, all these things. So this is your right and your left. At this point, if the person feels vertiginous, it cannot be because of BPPV. Why?
Because gravity is not.
Because gravity, the lowest part in the head has not been changed by this. The calcium carbonate crystal is occupying the lowest part in that semicircular canal. By doing this, I have not changed the lowest part. Okay? I have not changed the lowest part. So at this, the person suddenly starts developing an oblique nystagmus and starts protesting, sir. You are actually looking at rotational vertebral arteries. Person does not tell anything, is already unconscious. Carotid sinus hypersensitivity. Patient is generally dizzy and small nystagmus, tight neck muscles, migraine. Okay, this is the amount of information you get only with this. Correct? Next thing is you ask the person to pitch forward. Look forward as if wearing the shoes. Okay, with the VNG goggle, this is best done. Okay, if you have that. When you do this, if you get a nystagmus, just see the direction of nystagmus. If it is right-left nystagmus, lateral canal bleeding. If it is vertical torsional nystagmus, we are talking about it. If you are simply seeing only pure vertical nystagmus, mostly the person has migraine. Okay, so this one. After this,
migraine.
Okay, I do this on a couch, not on a chair. So that I stand behind the couch and I ask the person to look up. Look at the nystagmus. What happens? Next thing is ask the person to lie down, roll to this side. We do this on a couch. We make them actually. Sir, relax, no problem. I'm strong enough. I can hold it. Lie down. Okay, make them lie down on a couch to one side. Okay, this will activate if what our lateral canals are there. This will activate that. Okay. Then if that, give me one more step. And what you do, you change the position to legs. If posterior canal is there, it will get activated. Then again wake him up. Then go to the other side, same with pillow. After that, remove the pillow, make him look upwards. And then come back. You have done one screening test for BP. Whom all the patients who come to you with positional vertigo. And every elderly patient with any type of balance problem. Every elderly patient with any type of balance problems deserves BPPV to be screened. Is that fine? So this is all about all the examination techniques that you need. Blood pressure, pulse and blood pressure. Two things which only you should do or your GE machine should do, not the nurse. No offense to the nurse, but universally my thing is I take 3 minutes sometimes, 5 minutes sometimes to get the Korsakoff sound. My sister in all the hospitals, government, private, corporate has